Welcome to The Explainer. All right, today we're going to put on our detective hats because we're tackling one of the most fundamental skills in medicine. How do you take a single symptom and unravel the whole clinical mystery behind it? We're going to build a framework you can literally use for any patient, anytime.
Okay, so let's just dive right in with a classic scenario, right? A patient looks at you, they're worried, and they say, "I'm coughing up blood." What happens? Your mind just starts racing. A dozen possibilities, right? Is this just a simple infection, or is it something, really life-threatening? That sheer number of potential causes can feel totally overwhelming. But here's the thing, it really doesn't have to be.
Every great investigation starts with a single clue. And in medicine, that's the chief complaint. This is it. This is where the case officially opens. And our job as these clinical detectives is to understand that first clue with absolute, crystal clear precision.
So, back to our patient coughing up blood. The fancy medical term is hemoptysis. And what's so important here is that word precision. You have to ask, is this blood really coming from the lungs? Or, hey, could it be from a nosebleed they just swallowed? Or maybe it's actually coming up from their stomach. Getting this one little detail right from the get-go is absolutely crucial because it tells you exactly which body system you need to start investigating.
Okay, so the case is open. We've defined the complaint now. The real investigation begins. And we're not going to start by reaching for all the fancy, expensive tests. No. We start by gathering our first clues with the two most powerful, and I mean the most fundamental, tools in all of medicine.
That's right, I'm talking about your questions and your hands, seriously. Before you even think about a CT scanner or some complex blood test, you have your brain, which helps you ask the right questions, that's the history, and your hands for the physical exam. This stuff is the absolute bedrock of diagnosis. The story the patient tells you and the signs you uncover, that's what's going to guide every single decision you make from this point forward.
And this right here, this just illustrates that point perfectly. Just look at the very top of this diagnostic algorithm. See that first box? Everything. The entire pathway. It all starts with history and physical exam. It's not just some random first step. It's the critical decision point that directs the whole investigation. This is where you make your very first make-or-break judgment call.
So what's one of the very first things your history helps you figure out? Well, it's the quantity of the bleeding. Are we dealing with what we call non-massive hemoptysis, which, by the way, is the vast majority of cases, or is it massive? And let me tell you, this is not just some academic distinction. If it's massive, we're talking more than, say, half a cup of blood. That is a full-blown medical emergency. Your first job isn't even to diagnose anymore, it's to protect the patient's airway, right now.
All right, you've got your initial clues, you've defined the problem precisely, and you've got those key findings from your history and exam. So what's next? Well, now you move to the next phase. It's time to line up the usual suspects.
In medicine, we call this building a differential diagnosis. Basically, for hemoptysis, your list of suspects falls into a few major categories. Okay, could it be an infection? Something simple like bronchitis, or maybe something way more serious like TB. What about a malignancy? Or could it be a vascular problem, like a pulmonary embolism? Look, the key here is that you're not supposed to know the answer yet. The goal is just to create this big, comprehensive list of all the possibilities.
And this brings up a really key point. The framework we're talking about, the method, is totally universal, but the actual content, that changes with the clue. So for example, what if the chief complaint wasn't coughing out blood but difficulty swallowing, what we call dysphagia? Well, your list of suspects, as you can see here, would be completely different, right? Suddenly you're thinking about structural problems in the esophagus or maybe neurologic issues. See, the detective's method stays the same, but the suspects are always unique to the case.
Okay, let's recap. You've gathered your initial clues. You've lined up your suspects. Now it's time to follow the evidence. This is where you start using diagnostic tests, but strategically, to rule suspects in or rule them out, just narrowing your focus bit by bit until you finally zero in on the culprit.
Let's actually see how this works with another super common problem, edema or swelling. This table is great because it shows how clues from your history and exam can point you directly to a suspect organ system. So for instance, say a patient with edema tells you they get short of breath when they lie down. And then on your exam, you hear crackles in their lungs. What organ system immediately jumps to the top of your list? The heart, right? It has to be cardiac. The evidence you gathered in those first few minutes is already pointing you in a super clear direction for what to test next.
So you've got these initial clues, and they're all pointing you toward a certain system. But how do you confirm it? How do you actually use tests to navigate that really complex path to a final diagnosis? Okay, let's really dive into this full algorithm now. let's go back to our patient, the one with non-massive hemoptysis. So if they have 0 risk factors and their chest x-ray is totally normal, look what the algorithm says. The cause is probably just a simple infection, and we can treat that. Easy. But what if they do have risk factors, like a long history of smoking? Well, now the pathway sends us down a totally different branch. Now we're ordering a CT scan and maybe even a bronchoscopy after that. You see, every single test is a deliberate, logical step based on the evidence you've already collected.
So there you have it. We've followed the clues from one single symptom all the way to a potential diagnosis. We've cracked the case. But you know what? The real skill here isn't just solving this one mystery. It's about mastering the universal framework that lets you solve all of them.
So here it is, the whole clinical detective framework we've been building boiled down to 5 simple steps. Step 1, define the clue with absolute precision. Step 2, gather your initial evidence, history and physical. Step 3, line up all your suspects by building a broad differential. Step 4, follow the evidence with targeted, smart tests. And finally, step 5, crack the case, get that final diagnosis and create a treatment plan. That is the process. That, my friends, is the art of clinical reasoning.
And that really brings us to the most crucial takeaway of all. Look, anybody can memorize a long list of causes from a textbook, but a truly great clinician, they understand the process. They master the approach, and that is what allows you to confidently face any clinical mystery, no matter what walks through your door. So, as we wrap this up, I want to leave you with a question to think about. The very next time you walk into a patient's room, try not to just think about the final diagnosis. Instead, think about that first clue. Think about the very first question that's going to open the case. So, what will you ask your next patient?